Hi, everybody. How are you? I am very grateful on having Somer Baburek here with us. I will let her introduce herself shortly. I am Dr. José Gutiérrez. I am the Clinical Director of Fertilidad Integral. And today we get to talk about endometriosis. And the idea around this today is more than normalizing being able to talk about a very important disease. Somer Baburek is with us. She is founder and CEO of Hera Biotech and a leader on opinion in endometriosis and starting to lead a little bit changing the way we diagnose it. Thank you very much for being with us, Somer. And I want you to introduce yourself and talk a little bit about you.
Oh my goodness. Well, thank you so much for having me. It's an honor and a pleasure. And you've been so welcoming. So thank you. So my background is actually on the business side. So my education is in business. I have a master's focused in data analytics, and I come from 10 years working in life science venture capital. So we did drugs, diagnostics, and devices. And I worked in two of the companies in drug development. We exited those companies, and I really wanted to get back into women's health. I fell in love with women's health in my undergrad. When I had my first daughter, I invented a medical device around the labor and delivery with her, and I now have 3 daughters. So definitely motivated to change some things in women's health, and endometriosis was just a natural starting point for me.
Well, that's amazing. So, well, we know that 10% of women with endometriosis, of women will have endometriosis or a diagnosis of endometriosis. That's just if we pick them out. And if we're talking about women who have pain, recurrent pain with their menses, or women who are going through any kind of fertility treatment, there's a higher rate. It can go up to 30% in some of clinical studies. And what is it, Somer? What is endometriosis? Why is it important? Why is it associated with pain and fertility and this kind of, let's say, effects from the disease?
Sure. So in my very non-scientific way of explaining this, because obviously I'm not a physician and I'm not a scientist, but I get to spend a lot of time with them. So the easiest way to think about endometriosis is it is quite literally a disease where tissue similar to the lining of the uterus invades outside of the uterus and grows teeny tiny lesions like tumors anywhere in the peritoneal cavity, or from the bottom of the lungs all the way down into the deep bowel. And despite not being in the uterus, that tissue behaves exactly the same. So with hormonal fluctuations every month, it swells, it bleeds, it breaks down, and it causes a firestorm in your immune system and other systems of the body that doesn't recognize this behavior outside of its normal environment.
And what about the symptoms around it? Why have we normalized pain? What kind of symptoms are regulated? And we'll talk a little bit about the social part of how we normalize pain in women, no?
Yeah, absolutely. So there's quite a few symptoms that are associated with endometriosis, but they're also not specific to endometriosis. So they can be easily confused with symptoms of other conditions. Some of the most common symptoms of endometriosis are heavy bleeding during your menstrual cycle, pain associated with your menstrual cycle, bowel disruption throughout your month, and also pain with intercourse. Any of these things, along with many other smaller symptoms, can be associated with endometriosis. And, obviously, if you have endometriosis, you've experienced your menstrual cycle as it has always been. And so very few women actually realize that the pain or discomfort that they are feeling around their menstrual cycle is abnormal. So they think, well, my period has always been this way. I've always bled heavily. I've always had all of this pain. So that is a normal period for her. And it's very difficult, I think, to identify that actually that's not a normal period for a woman. It may be a normal period for you, but that is not what we would explain as a normal period in a woman in general.
Yeah, no, I do believe that as a medical community, first of all. Second, we know that from research purposes in medical therapies, women have been excluded in a lot of times, and with normalized pain around the period. So I think there are 2 points here, and that's something I want to talk to you today. First is to patients. Hey, pain is not normal. Okay, never. Okay, even if it's like pain and you've always experienced it, you do have to check why that pain is coming and make sure there is nothing behind it. And if there is, what can we do to improve quality of life? No, because there's a lot of times there are things to do to diminish pain, understanding certain diets, in patients who have dysmenorrhea, which would be just pain during their period, and it's not always related to endometriosis. We know that already. But if it is, why does it matter to? Well, that's one. No, and the second is helping our medical community also be sensitized to asking the right questions in the right way, to be able to understand which of these young women are having pain with their period and they've been normalizing it, because, like you said, always had pain, no? And culturally, we've allowed that pain to happen, no? 10, 50, 100 years ago, women would not complain about this because they were taught that they had to keep it quiet, that it was something they had to live with, this burden, no? Fortunately, today we're talking more about it, but we still have a long way to go as physicians, but also as a community to support these patients. But in this light, why is it so difficult to diagnose endometriosis? No?
Yeah, so I just want to make one quick point about pain. So I have endometriosis in my family, and I have 3 young girls approaching, menstrual age. And so the first thing that you talked about is, what is pain, right? I've always had pain. So the way that we quantify that in our household, rightly or wrongly, is uncomfortable during your menstrual cycle is okay. Pain is not okay. And those are different. And so our rule of thumb with our daughters is, if this can be controlled with ibuprofen or Tylenol, and this alleviates the symptoms, that is considered normal and that is fine. If ibuprofen or Tylenol or whatever your over-the-counter, pain medication is, cannot control your symptoms, this is when you should see a physician and ask about these symptoms. So that's kind of just a good barometer to give a normal human being on what is pain, what is uncomfortable, what is okay, what is not. So that's the barometer that we use. The other thing that's really important is to talk about these things, right, with your friends. And I have a very dear friend who is a very accomplished venture capitalist, and her rule is, say all the things all the time. That's the only way that we're going to make it okay to talk about these things. So have open conversations with people that you trust about your health, whether it's your menstrual health or whether it's things that you're experiencing in terms of your reproductive health or your mental health. Have the conversation, and that's the only way you're actually going to be able to judge what you're experiencing versus what other people are experiencing. But getting to your question in terms of what makes endometriosis so difficult to diagnose. So it starts with recognizing that symptoms patients are experiencing are actually symptoms of something and not just someone being dramatic or someone, having a difficult time. So that's the key. The second thing, and I always have to say this because we do this quite often, I'm going to come to the defense of my doctors in the sense that, when you're looking at a patient and she's telling you these symptoms, they are what's considered non-specific. Could be endometriosis, could be that you're just very susceptible to hormonal changes. And so you have big emotional swings, or you have, discomfort and pain. And what is pain? That's subjective. Could be that you've got IBS, or, there's a number of things that these symptoms could be indicative of. And unfortunately for the doctor, they don't have a tool in their tool belt today that they can use to say, oh, you know what, this could be endometriosis. Let's test for that. They don't have that option. The only means of definitive diagnosis for endometriosis is a surgical procedure. We at Hera lovingly refer to it as the Where's Waldo approach to diagnosis, which may not translate. But this is a children's book where it's, all these pictures and you have to go find the one person in this picture of millions. And so you are opening up a patient who may or may not have a disease that can be anywhere from the base of their lung all the way down to their bowel. The severity of their symptoms has nothing to do with the severity of the disease. So you could have a very painful patient that has a very teeny tiny lesion somewhere on her bowel, and it's the surgeon's job to go find it. I mean, that is just an impossible task, especially given that these lesions for endometriosis can present in over 7 different colors. They can be white, brown, blue, black, red. And so you don't even have a very defined target of what you're looking for. So it's a very, very difficult task. So doctors who are seeing a patient that may or may not have symptoms of endo are rightfully hesitant to recommend a surgery where we're just going to go explore your body and hopefully find something.
Yeah, it's true. And we always say endometriosis is associated with pain, but there are a lot of other symptoms. No, sometimes it's diarrhea or at the same constipation or with so there are so many symptoms around it that the doctor gets confused. And hey, doctors don't want to hurt patients, and doing a what we call in Spanish una cirugía blanca, white surgery, which just means you go in and you don't find anything, is frustrating. And of course, there are dangers associated, even though there are very low complication rates around laparoscopy, which is generally the surgery performed for endometriosis. We get it that we don't want to treat. And then the other question, why are we treating? No, is it symptoms? Is there something we can do? What are we doing with the patient? So there are a lot, not everybody's a laparoscopic expert. So this becomes, it's not the easiest surgeries actually doing for endometriosis. So what you do the diagnosis, then you go out and because you need to send them to an endometriosis specialist. And we, as an REI, as a reproductive specialist, I tend to see a lot of patients on with endometriosis. Why? Because women with endometriosis have a higher chance of infertility. It does not mean that all women with endometriosis have infertility, no? So then we start creating a little bit this, it's a very complex decision tree that we have to use to get these patients. And again, okay, we suspect endometriosis. Do we do a laparoscopy just to prove it to them? Because that's the other thing. Now, I really think it's endometriosis, but I can't be 100% sure unless today, like the gold standard for treatment, is a biopsy. So we have to take a little bit, and still, even if we see it and it looks the typical gunpowder vision, which is like the typical for our patients out there, it's the typical view. What they showed us in the book is a gunpowder kind of lesion, no? Or the endometrioma, which is a chocolate cyst. Those are the 2 typical findings around endometriosis. But as Somer said, we've gone into surgery and we said, oh, that looks weird. Let's biopsy, let's take it. And it was a little white thing, and it turned out to be endometriosis. Endometriosis. And you need to really train your eye to get this. I mean, it's not the easiest disease. Why is this important? Because am I going to go to surgery, get the pathology, and once I have the pathology, see, now I can say you have endometriosis, no? It becomes a very complex idea on how we're doing diagnosis. And that's the gold standard. That's today what people say. Until you have the biopsy, you cannot be 100% sure of endometriosis. But what other techniques are there out there? And what are you doing at Hera to try to improve the diagnosis, diminish the complexity around diagnosis, and actually do a less invasive testing for patients with suspected endometriosis?
Yeah. So currently, the process that you just outlined is really the only means of definitive diagnosis. Now, we run across, let's call them clinicians, or, people who say, oh, I am excellent at diagnosing endometriosis from whatever medium, right? MRI, ultrasound, whatever. Perhaps that's true. However, you are one person, and if we can't replicate what you do, that's not really helpful on scale. So, that's kind of, you'll hear that sometimes. And I would advise patients to just tread cautiously. If someone says, oh, I do this all the time, I know, I can tell from, an ultrasound that's not clinically proven. So, okay. But you choose for you. What Hera is doing is, so let me go backwards to go forwards. We understand very little about endometriosis. It has not been studied. Scientists still argue over how it actually begins. Where does endometriosis start? When does endometriosis start? The prevailing hypothesis for how endometriosis begins is, somewhere in the order of 95% of women undergo a process called retrograde menstruation. And this is where a portion of the lining of your uterus that would normally slough off and be passed through the vagina is actually refluxed back up through the fallopian tubes and escapes into your peritoneal cavity. And these cells then can land on tissue and begin to proliferate. That's the prevailing hypothesis of how it gets there. Whether you like that hypothesis or not, it doesn't matter. It gets there. And so what Hera said, our approach to this was a very oncology-based approach, which was, we don't really care how the tissue gets there. What we want to understand is how and why does it invade? And so we took that approach in looking at endometriosis. And in doing so, we started with the source tissue, right? So the endometrial lining. What is different about the endometrial lining in patients that have endometriosis and patients that don't? And so we started there, and we've done a number of experiments and tons of scientific bench work to show that misregulation of certain genes in the endometrial lining can lead to invasive behavior in these cells. And so what we are looking for in our diagnostic is we take a sample of the endometrial lining. This is very common, like in your practice of reproductive endocrinology. This is done all the time for endometrial receptivity testing. It's done commonly in OB-GYN to investigate heavy bleeding or unexpected bleeding of the uterine lining. And it's called an endometrial biopsy. And we just literally take a piece of tissue from the lining of your uterus. And what we do is we analyze that tissue, and we're specifically looking at gene signatures that we have seen are very predictive of whether or not the patient has endometriosis. This is important. There are others in the space focused on other ways of looking at this. They're way downstream, trying to look at the blood. The problems with those, in my opinion, is not all endometriosis lesions have access to blood supply. And in order to detect the biomarkers that you're trying to detect way downstream, there would have to be substantial amounts of them leached into the blood in order for you to detect them. So we decided to start at the source tissue and try to understand what's happening there that then leads to the formation of endometriosis. And what we're hopeful is, yes, we have diagnostic assays in development. We intend to have those in market in Q1 of 2026 in the US, and then we'll be moving into Latin America and other countries. But we also hope to better understand the disease based on the work that we're doing in the tissue. Why does it progress quickly in some patients and not in others? Why are there different types? Are there different subtypes, genotypes, phenotypes? What's happening, right? So that's what our big goal is, to better understand this disease and why it progresses the way that it does in some patients versus others.
I mean, that's really, really interesting. So yeah, the theorem, we don't know how endometriosis comes, no? So we know there is the reason you're doing oncological is because there's a neoplastic behavior, which means it behaves kind of like cancer in the fact that it's able to spread. It is not a cancer, so let's be clear. This is not a cancer, but it has certain components that are similar to cancer, that it's able to spread from one tissue to the other and do this implantation. So the markers are, it's very amazing what you're doing. And so what you want to see is who has the risk or a very high risk of being able to have this implantation, and that way go through, I'm guessing, plus symptoms. What have you guys seen, like sensitivity, specificity? So for others, of 100 patients that you say you have endometriosis, where are you guys at? Because if we're taking away, let's say you have a patient with pain and I'm not sure and I don't have anything else, the MRI, all my tool belt, I'm still not sure whether the patient has or not. And it takes, and we also have to talk about cost, and we will, but MRI is expensive. It's not good enough, but it's good enough. It's still not perfect, but MRIs are expensive and we don't have them everywhere. Doing a biopsy, you can do it anywhere around the world, and then you will send the tissue. That's pathology. Every doctor has access to pathology specimens and to be able to send specimens, no? But well, I'm not sure. So then I will be taking the biopsy to see if she has, no? So we do the testing. How is Hera Biotech? Like, talk a little bit about sensitivity, specificity, and for everybody out there, this means of 100 patients I do the test, that have endometriosis, how many I'm actually gonna find, no?
Yeah. So what's really important is that Hera intends to only go after symptomatic patients. So a patient presents, she comes in, she has symptoms of endometriosis. We are the test that the doctor has in their tool belt that they can give. As you mentioned, every doctor has access to pathology, and that's the important piece. We can do it right then and there. So it's also really important to talk about Hera's clinical standard. So you'll see that some people accept empirical diagnosis, meaning the doctor thinks it's endo, so we're calling it endo, or ultrasound or visualization even during surgery. And to your point about the expertise, and you have to train your eye for this, it's an interesting statistic, but of the biopsies taken during these surgeries, you take multiple spots, right? Because you see things and you want to make sure, just like you pointed out. 50% of what is taken during a surgery is not endometriosis. It doesn't mean that she doesn't have it. It just means that there's a lot of things in the body that look a little strange or might not be exactly right. And so, even your trained surgeon who's sitting right there looking at the disease has difficulty. So for Hera, our comparator is the pathology. So all of our patients on our clinical trials have pathology reports to back up the findings from surgery. And that's really important, right? Because that is the gold standard. We aim to replace the surgery. So our goal is to be a rule in. And in order to do that, what we focus on is specificity. That is where you really focus when you want a rule in definitive diagnostic. When you're talking about a screening test, where you're testing anybody and everybody to see whether or not they're likely to have endometriosis, you want to optimize for sensitivity. So you want as many positives as you possibly can so that they can funnel into more definitive treatment. We are coming from the other way. We don't want to funnel a bunch of people in. We very narrowly want to focus on who actually has this. And so our sensitivity is around 80%. We have 2 tests in development. One's a little higher than 80, but the other one's at 80. And then our specificity is at 95. So very strong specificity, which is what we want. And then, we're happy with the sensitivity. I think that actually competes with the strep test. So I'm happy with that sensitivity. So that's our focus, and that's where we fall in the spectrum. There are, I talked a little bit about the blood tests that you see out there. If something like that showed to be clinically useful, the focus of that test would be a screening test. Cast a big wide net, get as many people as you can in the funnel, because that's where you can filter them, right? So that's not our focus. That's not where we intend to play. So I think that answered your questions on that piece of it.
I'm just going to bring it down. So this would mean that if I have a patient that has a clinical probability of having endometriosis, and I do the Hera Biotech's test, the idea is that 90, and it says they do have endometriosis. Out of 100 patients, when I do the surgery, if they need surgery, because then not all patients with endometriosis need surgery. Okay, there are other treatments, and we'll talk a little, because this is beautiful for that. Then 95%, if they would have surgery, they will be confirmed of actually having endometriosis, and there'll be 5% false positive, which wouldn't be evidenced endometriosis, that we couldn't find the evidence in the biopsy. Am I correct?
That's correct. Yeah. So, and we know that we're going to have a little bit of a false positive rate for exactly the reason that you just talked about.
All tests do.
So,
some will be true false positives, and others just the surgeon couldn't find that small lesion in the bowel. Right. That we also have to own that. I mean, I've been involved in endometriosis enough time to see changes, and there are a lot of changes also historically. But for me, this is amazing, Somer, because as we're talking, I start my mind goes working. Like, this is not something we don't have yet the tree on how we're gonna use Hera. We can have theoretical ways, no? But today, as we grow our reproductive field, and we see a lot more patients, we start to notice that as we have older patients that have endometriosis, we're steering a little bit away from surgery treatment on patients that are coming in for infertility. Why? Because we're dropping the rate of, we can diminish the number of eggs we have. So every time more, and it can be a big discussion. If I have 10 REI specialists here, we'll be fighting who's where. But every time more, we're steering away from surgery because we don't want to lower the ovarian count and we do surgery. But classically, when we do surgery, if you do surgery and you're a reproductive surgeon and you see endometriosis, it's like, oh, I'm gonna kill that bastard. No, like we want to take it out. That's how we were trained. No, but we can also do harm because when you take endometriosis, when you have to do surgery for endometriosis and it's impacting the ovary, we have to take away a little bit of the healthy ovary just to be able to extract it all. And when we do that, we tend to diminish ovarian reserve, and there are every patient has to be individualized. Okay. And when we're talking only about reproductive, today there's a lot of tendency of steering away from surgery and leaving the endometriosis as it is, understanding that this will cause certain limitations, but the benefit outweighs the risk on not doing the surgery. But if we do the surgery, I know because my friends I'm already here, like not touching the endometriosis when you're seeing it is very hard and counterproducing. There are a lot of things that will be discussed here. But if I already know, if I can prove the diagnosis to the patient, but explain to her the benefits of not doing a surgery, because there sometimes we need to understand that not all endometriosis has to be treated. This is great because I can actually prove to her she had the disease, or not prove to her, but highly likely give her the evidence. I'm not saying I think you have endometriosis, but hey, 95% sure of having endometriosis, but we will treat it in this way because we want to maintain your reproductive. Guys, everybody here, pain is not normal. And sometimes you need to do surgery for endometriosis to get the pain out. That's for me, hey, let's not normalize pain. If you have pain or bowel symptoms, a lot of times your best bet will be surgical treatment because we want to impact quality of life. But on women with mild symptoms and who are looking more to protect their fertility, there are other treatment plans that we can think about, whether it's egg freezing, hormones to diminish the progression. And this is why I'm getting there, because we classically, when we can, use hormones to try to diminish symptoms for patients, one, because quality of life matters, and two, we're looking to diminish the progression of the symptom because we classically know that these lesions react to hormones, and especially estrogens. And the question here, and this is my question to you, is whether if we diminish the dosing on estrogen, can we diminish the progression? How do we stop this neoplastic, so kind of tissue being able to expand around it? And my question is, what have you found on these markers? Why is, because we don't know, or I don't know.
Yeah.
Why can these lesions leach on to tissue that they're not supposed to be there? And is it only hormones? Is progesterone helping? Is every patient different? What have you guys found out? Because I love the diagnosis and I love helping women, but I also love that you guys are going to be able to understand the disease much better than what we know today.
Yeah. So that's the $1 billion question, right? If you can answer that question, we're talking about, multiple unicorn kind of company. But what I will say is based on the work that we're doing, and our work is so impactful, but it's also important to talk about the vastness of what we're doing. So we have the largest single cell and bulk expression libraries with women with endometriosis, and controls are in there as well. So we have 14 billion data points in our data sets. And those are multiple data sets, but that's important. And so our poor computational biologist just has to kind of drink from a fire hose at all times. What I can tell you that we see is we are all fairly in agreement that it's an epigenetic problem, right? You may have a genetic predisposition to endometriosis. We've seen that. We know that moms and daughters, tend to follow the lineage, right? Your mom has endo, you're at a higher chance of having it, etc. We don't, it's not, I've heard this before from a very angry patient who was like, you should be focusing on CRISPR technology. And I thought, well, what gene is it that you'd like for me to edit? That's
and that affects everything else.
We'll just clip that one and hope for the best. Yeah. So, it's not a single gene. This is not a single gene test. It's not like if you're expressing this gene, you have it, you don't. No, it is, it's epigenetic. So you may have a genetic predisposition, but without certain other factors, you may never develop the disease. So it's important to talk about that. It's also important to say that it is absolutely tied to hormonal changes. We do see consistencies, not only in the genes, but also in hormone levels there. But from the bench work that we did in the early days, what we were able to show is, for example, one of our patents covers gap junction genes, which is the gene of interest for us when we started. Gap junction genes, their primary role is mediating invasive cell behavior. So everybody thinks like, oh, invasive cell behavior, cancer. Well, sure, cancer is invasive, just like endometriosis is invasive. But when you think about invasive cell behavior in the uterine lining, it's really important because it's required for fertility, for embryo implantation, vascularization, decidualization. So all of these processes around fertility are tied to invasive cell behavior. And what we found is when you take cells from the endometrial lining that have a misregulation in their gap junction function, no pun intended, and you introduce them essentially into a peritoneal cavity in a dish, when they interact with mesothelial tissue, which happens to be the main tissue type that you have in your peritoneal cavity, you see this huge induction and the mesothelial tissue moves apart. These cells drop in and begin to proliferate. So it's literally the genesis of lesion formation. So we then took this exercise and moved it over into and tried to prove that, well, mesothelial tissue in patients with endo is more susceptible to invasion than mesothelial tissue in non-endo patients. Nope, absolutely same response. So no difference in the receptive tissue, only in the cells that interacted with it. And then we repeated it and we, through silencing RNAs, knocked out that gap junction misregulation and we saw no induction. So these are the kinds of things that we're trying to understand. How do we stop progression? How do we keep it from moving? And to answer your question, there isn't a silver bullet out there that we know stops progression. What we do know is that endo is an estrogen hungry disease. So if you feed it estrogen, you're going to get, a outsized response, so to speak. And so that's why it's so important as it relates to fertility, because every reproductive endocrinologist we've talked to about this, not you, because I haven't asked you the question yet, but they would change something about their care path for the patient if they knew she had endo before they started. And that can be a number of different things. We have heard everything from, I would change the embryo transfer protocol because I think if you implant embryos here, it would be better for endo patients. I can't speak to that. I'm not an endocrinologist or a reproductive endocrinologist. But I think that in and of itself is evidence of why it is so important to know up front whether that patient has endometriosis or not, because it does give you information that would likely change what your recommendations are for the patient. There's only one doctor that said she wouldn't change anything about how she treated the patient. But then she said, but I would still give your test. And I thought, why? If you wouldn't change anything, there's no point in giving my test. And she said, mental health of my patient is so important before we go through this path. If I can show her a test that says, this is not you, this is a disease, and we're going to move forward and we're going to do what we can to be successful. This is not your fault. She said, that in and of itself has enough impact on my patient for it to be worth giving your test. And I thought, okay, I mean, I'm glad you want to give the test. It's not exactly how I thought it would be administered, but I appreciate it.
I actually like your doctor because she is saying, show me the evidence that changing something will help my patient. And then she probably will, because we tend to do on endometriosis a lot of changing or protocols on theoretically based evidence, medicine, which it means I think, and I think has been done because there's a lot of non-understanding. I love that you said, no, it's not the receiving tissue, it's the attacking tissue. So that means that endometriosis, you proved that, no, that endometriosis is coming in from the endometrial lining. So of course there are going to be changes in implantation potential or possibility of getting pregnant, small or large, and could we do something or not? But also, how do we protect patients? No, like, hey, a girl with pain that doesn't experience any ultrasound diagnosis or maybe not even any MRI, but we think pain and we have to differentiate. Hey, we classically give standard birth control pills. They have estrogen. No, that's what we normally give for pain on patients. But hey, are we doing the best for patients? It's not the same dysmenorrhea, so pain with your period, then patients with PCOS, then patients with endometriosis. And should this girls, and I'm just saying it out there, and there's
Yeah.
no research to be done, but should there be progesterone only pills if they're going to go through something? And would that protect them to diminish the risk of needing a surgery later or a reproductive treatment? So,
Yeah. I mean, it's anecdotal evidence, right? Because again, never been formally diagnosed, whatever. Had horrible periods my whole life. Estrogen birth control just makes me ill. It just, even the lightest dosage, it's just not, I'm not well. Let's just say that. I finally, and this is another thing, right? Okay, I am 40 years old. I am in the space of endometriosis. And it wasn't until about a year and a half ago where I actually had the gumption to say, no, I don't want that. I don't want that anymore. I don't want that IUD. I've had 3 of them in bed. Please stop telling me that the IUDs are the best thing. I want to try a progesterone-based birth control. I had to go out, find a company that made a progesterone, then ask for the prescription for my doctor, got some pushback on that, but finally said, I will find someone who will prescribe this. I want to try it, please. And so she did. And I'm not kidding you. First of all, I take my pills so I don't have to have a period now. But for the first 6 months I took it, I thought to myself, oh, that's why no one thinks their period is that big of a deal, because they don't have to wear a, Supermax pad plus heavy tampon and hope that it doesn't look like a murder scene in their bed during their period if they sleep through their alarm, which tells them to, change their tampon. So, it's not easy to do this. It's not easy to recognize, even for people that are in the space. And so, I always try to just tell people, just say the thing, because trust me, like no one, even people who should know better, they don't know either. So just don't be afraid to ask the question. Don't be afraid to say, I'm concerned that this might not be normal and I don't know.
Somer, I'm first of all, congratulations. This is the month of endometriosis. Guys, men, be aware of this. This exists. Let's help our community of women actually not normalize pain. Somer, congratulations. I think what you guys are doing is amazing. I think it's a big step on the right direction. I think we need to I'm a trained surgeon, so I love surgery, of course, but I do believe we have to find ways to actually help people have the information to be able to take the right decisions, help scientists get the right patients to be able to do the correct research around it. And I'm super happy you're here. We want to talk about different subjects. Endometriosis for me is one of the most important ones around reproductive treatment, because it hits all the points. It hits fertility situation. It hits the fact that that research classically in medicine doesn't go, a lot of the funding doesn't go towards women. Today it's changing, but we're still far away from where we should be. It goes towards quality of life, and finally actually getting tools for doctors to help female patients not experience, 1, pain, 2, complex surgeries, because this disease progresses, and we're not going to take the endometriosis out of the world, but if we're able to prevent it in the way of it progressing into more severe disease, it's very different treating and diagnosing early endometriosis versus late onset endometriosis, which are actually the patient, like you said, don't have symptoms, but have bladder involvement, and it's a 10-hour surgery, and it's a high-risk surgery. We want to avoid it, no? We want to get to that point. And finally, giving the tools to people who do have endometriosis at an early stage, say, hey, do you want children? No. Do you want to prevent this disease? Should you be doing egg freezing? And I always say, not everybody has to freeze their eggs. Everybody has to know it's a tool that exists to improve their clinical outcome when they're ready to be parents. So, Somer, it's a pleasure to meet you. It's
a pleasure to me too. Thank you for having me. And I will just say one thing that I love. I heard this quote at a conference, and it was all around, why should we prioritize this kind of research and this kind of discussion points? And it's because these topics affect the 51% of the population that will birth 100% of the future. So that's why it's important. guys and girls, let's all talk about it.
Yes, let's talk about it. Let's open the conversation. Please, any comments, share them with us. The team will go either towards me if it's a medical situation, towards Somer if it's something around Hera. Want to open the conversation, share thoughts, everything. And I hope we have a lot of this stuff, Somer. It's been a pleasure. Thank you for your time.
Thank you so much.